here or wants to look at it later, they can do it. So it's now recording. So what I was going to cover today was the slides that I sent you with the recording. So if anyone's got any questions on that, I'll do that first. And then the quiz that I sent you that Tamsin said she would post up, I would do that next. And then any generic questions. And then I've got a Mentimeter quiz for you, so we can do that one after. So has anybody got any questions, first of all, then, on the slides that I sent over with the recording over? It was in several parts. Let's see what comes up. 6 of you watching on one screen. I hope you're staying apart from each other. No questions on those? Oh, hang on, we've got people typing, so wait and see what they say. Oh, we couldn't find the slides in the recording. Oh no. So if I share my screen, oh no. Tamsin, if you're there, can you unmute your microphone and see if they were on there, or did anyone find them? Okay, so you found some slides, but not the sort of the talk over bit. I think we'd probably better do that instead then, hadn't we? The Tamsin's just typing to us. I think we'd probably best turn this into a teaching session instead then. Okay. Did anybody find the set of slides and the talk over bit? Because I'll just do it as a teaching session instead. Okay, so I'm showing my screen now. Can everybody see my screen? Yeah, okay, so if I flip over here, Tamsin, can you WhatsApp me if they're not coming across? And what I'm going to do is I'll just do the presentation, I think, instead to you, because I think if people haven't seen it, then that's probably, thanks Tamsin, I think that's probably going to be more useful to you, isn't it? So let me take you through the slides, and that's probably going to be better use of our time. So clinical pharmacology, that's what we're doing today. Let's move that on. Okay, so I'm getting some messages back, so it's obviously working. Okay, so this is the sort of stuff that's on here. So we wanted to talk a little bit about how medicines are regulated, because it's really important that we understand a little bit about that. Then I'll go through a bit of pharmacokinetics, which is how the drugs move through the body, and then a little bit about pharmacodynamics, which is how they work. Then we'll talk a little bit about how they're sort of made, a bit about sort of mechanisms of their action, and then sort of different routes that you can administer them via. So next slide. So it all came about because in the 1960s, and there was a drug called thalidomide, and it got licensed in the UK and other countries. It was for morning sickness, and we didn't realise how unsafe it was until a load of kids were born with deformities, and actually a lot of them were stillborn as well, died in utero. And so that was the sort of start of the regulation process. So I think it really highlights to us that drugs are really useful, we need them around, but they're also very dangerous as well, and we need to take care with them. So incidentally, I love this picture because these kids are just being kids, and that's what they do, isn't it? They never listen to teachers. So I like that picture. But that was where it all started about. And what we need to remember is that they are dangerous, and they're special products. We need to take care with them. And there's a load of legislation written. So it started off with the Medicines Act in 1968. And then in 2012, they've put it all together and they've made the Human Medicines Regulations 2012. So that's the sort of overarching legislation that you need to look at. If you're looking at sort of legislation, it would be under that one. Now, there's different places around that regulate medicines. So if you're regulating just in the UK, you go for the Medicines and Healthcare Regulatory Agency. So it's the MHRA, and they just will regulate just on UK soil. So if you just wanted to make another paracetamol, then you would go through the MHRA for your license to sell it, and they would give you that, because places like Spain and France and everywhere else, they don't really care if we just make another paracetamol. You don't have to license it across the whole of Europe. If you want a license to sell your medicine across Europe, then you would get it licensed through the European Medicines Agency, the EMA. And that is for things like sort of diabetes medications and novel things. So we have an agreement with Europe. I know it's coming up, Brexit and all that. But we have an agreement with Europe that we will share the way that we use our medicines across the whole of the EU, and that's for the benefit of everybody. So there's two different agencies there. You've got the MHRA on our soil and then the European Medicines Agency, and they do kind of the same thing, but just in different areas for sort of so MHRA is just for your sort of things like your paracetamol, but European Medicines Agency would do like the sort of bigger things that get licensed all across Europe. So you're going to tell me we've just left Europe. That's true, but I think as much as the legislation that's in place may change a little bit, I think it'll stay pretty much the same. We have 3 countries that are not in the EU, but are in the EC, and they do exactly the same thing as the rest of us. So it's Liechtenstein, Iceland, and Norway, and so they share exactly the same way that we do. So I imagine it will continue. But regulations and directives and statutory instruments are your sort of legal things that you're looking at, but they'll change just a little bit with this new Brexit thing. And when we're looking at medicines and the way that we license them, we need to look at 3 things, and that is safety, quality, and efficacy. So they need to be safe, they need to be high quality, and they need to work. And it doesn't say there, we need to know how they work. So that's really interesting, because we know sort of paracetamol works. We're not quite sure how. There's a few different theories on it. So you don't have to prove that, but you do have to prove that it works. Ooh, everything all right so far? Do keep checking back to you to make sure that you're not typing me things, but you can hear me all right and it's clear. Mark and Toby are typing to me. Great, okay, thank you. So I'll continue. So that's a little bit about the sort of regulation and what covers it. So just some definitions for you. There's a slight difference here, and we use these terms interchangeably, but actually they're different. So a drug is a substance which has an effect. So that is like your white powder up the top right here, just that very small amount. So if you took a tablet of Ramipril, it would be the 10 milligrams, the very tiny amount of active substance in that would be the drug. If we're talking about a medicine, then that is that picture on the bottom right here. It's the whole preparation. Some people say it's even like the bottle, whatever it comes in, and even the leaflet as well. But it is that wider thing, the whole tablet, not just the active substance. And then people say pharmacology is the study of drugs. Well, I disagree, because I think it's the study of medicines, because it is the study of the whole thing and how it works. And part of its being in a sort of a vehicle is that is what you've designed it for. You want to manipulate that, and we'll find out a bit more about that in a moment. So here's some law. That one's a directive. It's an EC one, so it'll change, but we'll still keep the wording of this one. So note that to have a license for a medicinal product and to be done in law because you're selling medicines, you notice the top one up here is a description of a medicine as we would know it. But this second one talks about something if you have a view to restoring it, because you are presenting it in such a way that you, the top one here, sorry, if you present it in such a way that you have properties for treating or preventing disease, then it's a medicine. So if I put a load of chewing gum into a packet and said, take these 4 times a day for your constipation, then I'm selling a medicine. So even though we don't recognize chewing gum as a medicine, if I package it up in such a way, then it's still a medicine, and I need to just be careful because I can be done by law for that one. So note those definitions. If you have a click on these later, these are the schedules of the medicines, schedules of exemptions. So there is a piece of legislation that says we can't just dish out medicines willy-nilly, and you can't store medicines and things like that. But we paramedics work under exemptions to that. So we are allowed to do things that other people aren't allowed to do. So Schedule 17 is in an emergency. I'm going to try and click on this actually and see if it works. I think it's going to let me. No. Have a click on that one later. But Schedule 17 lists a load of medicines. No, I've got it wrong. Schedule 17 is an exemption for paramedics. And what it does is it allows paramedics to give certain medications in certain conditions. So if you have a click on that one, you'll see, if you scroll all the way down, you'll see paramedics listed. You'll see a load of medicines that they're allowed to give. Note that it doesn't say student paramedics, whereas it does say student midwives. And it's a really specific list. If you click on Schedule 19 down here, then you'll see that one is a list of medicines to give it in an emergency. And that will list a certain list of drugs that anybody can give in an emergency. And you'll notice that there are things like glucagon, so that can be given by anybody, and that allows people like community responders to give those. What it doesn't cover is things like inhaled medicines like salbutamol. So, and there's a bit of a loophole in those ones. These are just the injectable ones that are covered under the Schedule 17 and 19 exemptions. But inhalation medicines like salbutamol are not covered by that at all. And that's how community responders give those ones. So it's a bit of an anomaly, and it's something that we're looking into because we want it a bit more tightly regulated, but we also want the medicines out there. And then this article here is by Ed England, who was gas pharmacist. And it's really good. And it talks to you about all the sort of legal bits. It really picks it up well. But generally, we give our medicines by these set of exemptions. One is for paramedics, and the other one is in an emergency, which allows anyone to give it in an emergency. So note, if it's a Schedule 17 drug for paramedics only, you can't allow anybody else to give it. So I can't hand the syringe over to somebody. But if it's a 19 one, I can allow them to give that one legally. So we just said about that one. So things like oral medicines and things like salbutamol, because they're inhalation and oral and not injectables, are not covered. So it's a bit sort of woolly, but that's how we get around it. Now, drugs are given really stupid names. It's really irritating. But they get a chemical name. So this one here, 1,4-ethoxy-3, rolls off the tongue really well. It's the substituted side chain of a methyl piperazide. Really hard to remember, but it's what the scientists use when they're developing it. It'll show you where all the bonds are on that chemical. They also get a generic or a scientific or a non-proprietary name. And the one that I picked out was sildenafil. So that one is the name that you have to get permission to call it that one. So things like the beta blockers are all called olol at the end. So I might call a new one Samolol, but I couldn't call it Samafil or something like that. So there is a bit of a regulation about what you call it. Then you can come along and you can give it your own brand or trademark or proprietary name. So sildenafil is also named as Viagra, so you'll know that one, or Revatio. And that is what the drugs company decide to call it. So they've given it the name Viagra, and they've also given it the name Revatio. So Viagra is for, I can't remember the technical name, I'm going to make a fool of myself, so I won't say it. But Revatio is for pulmonary hypertension. So they didn't want people to erectile dysfunction, that was the word for Viagra, but Revatio is for pulmonary hypertension. So they didn't want the two brands sort of mixed up. They wanted people who had pulmonary hypertension to take this medicine and not be embarrassed by taking Viagra. So they called it two different things, but they do both contain sildenafil, and they are exactly the same thing, but just licensed differently. Pulmonary hypertension, thanks. Somebody made a paper, and it was called Multiple Brand Names for the Same Generic Drug Can Cause Confusion. And they've got this published somehow. So I popped this little picture in because it is really obvious. They are really confusing, aren't they? So calling it Viagra and Revatio, confusing stuff. The World Health Organization come along again, and they give things another name. And it's an anatomical therapeutic chemical classification system, and it looks a bit like this, G04BE03. And drugs will get different names depending on its use. So things like aspirin get several different things. So it's sort of anti-clotting, it's an analgesia, it's an antipyrexic. So they'll get 3 different names for those different functions. You won't really see that unless you get into some sort of a concentration camp, into some sort of camp where the World Health Organization, like a refugee camp or something like that, or maybe with this new virus, we might get people treated by the World Health Organization, where we're all trying to work together, and you'll see certain drugs given under that name. So that's the only time you really might notice that one. And that's what it's called. That's their logo. So if you see something like that and people are under a World Health Organization, you might see the drug listed as that. You can look it up in their books. Right, any comments? Nope. So drugs are classified in different ways. You can classify it on supply status. So prescription only medicine, POM, that's one that you have to get a doctor or a prescriber to write you a prescription for it. And things are given a POM status because they're either dangerous, or we want to control them, or you need a pretty good diagnosis to be able to take it. So if we take Ramipril, for example, you don't want Doris to go to the shops, pick up some Ramipril, think, oh, I think I've got a bit of hypertension, I'll take that medicine. You need her to go to the GP, be checked out, make sure she definitely has hypertension, and then they will control the way in which she receives that medication. So that's what it's done. So stuff like morphine, it's never going to be a pharmacy medicine. It's always going to be under prescription. P is for pharmacy. So you need to go to the pharmacy, and generally the person behind the counter just sort of shows it to the pharmacist just to show what they're giving out. And those are things like if you wanted a sort of an eye drops or something like that, just a little bit more regulation is needed to be able to give those out. So we again don't want them on supermarket shelves, but we want the drugs readily available and out there so people can get their hands on them. But it just needs a little bit more checking that you definitely have got those symptoms before you go taking those medicines. And then GSL is general sales list. So those are things like paracetamol and ibuprofen that you find on the shop floor of the supermarkets. The only restriction about GSL medicines is that you have to be able to lock your premises. So you can't find them, you shouldn't find them sold from things like market stores and things like that. It has to be able to shut the door up. So if it's a petrol station, it has to be able to lock up its premises to restrict access to them. So Veronica's asked, are we able to prescribe anything? Not yet. People are currently on the prescribing course as paramedics. To get on the prescribing course, you have to have a reason in your job to be able to do it, and you have to have the governance in place to do that. So it is quite tricky. So we can't all just pop on a prescribing course. You have to have a sort of reason and some sort of setup in your organisation where it's required. So currently, it's only the hospital paramedics that are getting on the prescribing courses because they have sort of doctors and people around that can watch them at the moment. But hopefully that will open the gateway to more and more classes of paramedics getting it. So good question, thank you. So P and GSL, these are called over-the-counter medicines. So both P and the GSL are called that. So if you hear an over-the-counter medicine, it is a P or a GSL, so don't be muddled with that one. How also we can classify things is by either calling them a small molecule or a biopharmaceutical. So small molecules are made in labs with chemicals. Biopharmaceuticals are generally made in big vats, and you use sort of bacteria to multiply up what you're making. They're sort of biological compounds. A lot of them for things like sort of asthma and things like that, and then most of them have got to be kept in the fridge. You can classify them by route of administration, so you can say it's like an IV medicine or an oral one. Where it works, so biological system. So these are the neuro drugs, and you can see there's loads of different fields that they work in and the way that they're classified. So stimulants, antipsychotics, and they all sort of interlink a little bit. And then the therapeutic effects it has. So you could say aspirin is like an antiplatelet drug or an antipyretic. So you can talk about how it works, and that's how you can classify it. We should talk a little bit about illegal drugs. So the Misuse of Drugs Act 1971 covers this, and it prevents people from selling things under that legislation that we talked about before, which is how you classify a drug. So if it's got a physiological changing property to it, it's a drug and you can't sell it. And the danger with these is we don't know how it's been made. It's not been regulated. They're not stored in proper packets. They're stored in sort of plastic bags, heated and cooled. And what that person first thought they made may not be true anymore. It may have broken down and turned into something very different. Also, when you're making medicines, if you're storing it, if you're making it in your bathtub, and the bonds have to be created at 50 degrees C and you heat it to 55, sometimes you can make different bonds in a different chemical. And so we really don't know what's going to be in that. So be very careful with people who've taken illegal drugs. It might not be pure, it might be mixed with things, and it might not be that at all. So if there's any doubt about it, I would take them to hospital, because that's the safest thing to do. It's not always a good idea to leave these people at home because it is a bit of an unknown quantity. So are codeine paracetamol combinations GSL? I think some of the lower doses of codeine come under a P designation. So you can get sort of lower dose ones from your pharmacy, I believe, but we can look into that one. So some, what's it got? Like Viagra now, you can get that one as a P. That's right, Eva. So some of the things like, oh, there we go. Suraj, I hope I said your name right. Small pack size up to 16. Yeah, so we do want things to be available through pharmacy. So you can get stuff like Viagra in very small packs. So you have to go to the licensing authority and you ask them. Oh, thank you. That's very kind of you to answer that one. So yeah, so codeine, paracetamol, 8 milligrams, 500 milligrams are pharmacy only. So yeah, so you can get them through pharmacies, but they will license very sort of small amounts for short periods of time. And like the anti-reflux medications, the antacids, they license very small packets of those through the pharmacy just to get them out there for people so that they can help themselves. So one thing that's really important to understand is that patients don't take their medicines as they're supposed to. If you have a look at the data, there's a reference there, but about 50% of people take their medicines as they are supposed to in the Western world for chronic illnesses. Isn't that really funny? So we give out all these medicines and about 50% of people will take them as they're supposed to. It's quite a range. So how do you define non-adherent? So is it that you don't take one or you don't take all of them? So the definition of adherence is really hard to define, but also like patients, non-adherent patients, there isn't just a classic person. It's not somebody who's a sort of low earner. All sorts of different people don't take their medicines for different reasons, and that's something that we can have play a part in helping. So I'd set this one up. I won't make you do it, but just have a think. Oh, actually, we could do this, couldn't we, as a talk on here? Tell me why. Oh, thank you, John. John's posted a link there. So tell me why patients don't take their medicines. Just chuck a few things on the chat there. And you'll be bored of hearing me talk, so Let's give you a minute. Oh, great. Some side effects. They're saving them up. Ooh, what's worrying, isn't it? Mental health reasons, paranoia. Yeah, very real reasons, aren't they? Don't think they help, so they don't buy into that effect. They make them feel like they're being controlled. Yeah. Think they know better. Religious. Does not work. Fear. Scared of side effects. Oh, hang on, it's moving too fast. Control. Don't like the taste. Yeah. They just forget. Yeah. Very valid. They don't agree with their medications. Cost. Yeah. Feel better. They gain weight or weight loss. Don't know why they have to take them. Too big. Yeah. The tablets. Remind me to tell you about their horse tablets. Cost, unnatural, where they become dependent. Conspiracy theorists. Yeah. Yeah. All valid reasons. Yeah, so if we pick up on the too big, my friend went to somebody who had these really massive tablets, and she said, "Oh, I just can't swallow them, dear." And when he asked her, she was trying to swallow these things, and actually they were suppositories, but nobody had explained that to her. So bit of a fail there, wasn't it? But fed up with side effects, being withheld from them, feel it's useless, learning disability reasons, yeah, unsupervised. Increases or decreases depending on the day-to-day feelings or symptoms. Brilliant. So there's two different branches of not taking them. Can you think of how we could divide these up? So if we say weight gain would be on one side of it, cost would be on another, don't believe that they work would be on that one. And then on the other side, things like they forget to take them. Learning disability reasons might be on that other side. Medical versus non-medical reasons. It wasn't the one I was thinking of, but it is a good one. Everybody's typing. Physical, mental. Ah, oh, hang on. And somebody's got it. Brilliant. Yeah, so Eva, you've got the prize for that one. Well done. So yeah, there's two branches that the literature looked at, and that is intentional and unintentional reasons. So if you look at these, so if somebody feels it's useless, then they would be somebody who intentionally wouldn't take their medicines. If somebody's got learning disabilities, then they might not be able to understand how to take them. So that would be an unintentional reason. If they can't afford it, that would probably be an unintentional reason. So stuff like buying into the side effects, if buying into either the effect or the side effects, then that might be an intentional reason. If they feel like they're gaining weight, that might be an intentional reason why they don't take these things. Religious, again, intentional. Paranoia, a bit of both, really. Saving them up, that's definitely intentional, isn't it? So there's two branches of this. There's the ones that are deliberate and then the ones that are not deliberate. So people forgetting, can't afford it and things like that. So just be aware there's intentional non-adherence and unintentional non-adherence. And if you have a look into the literature, it turns out that the most important thing in whether people take their medicines is us, it's healthcare providers, especially the person who first prescribes that. So if you look at the things where they are intentionally non-adherent, they are things where the person who's prescribed it hasn't gone into enough detail to either sell why they need to take it or to explain to them that the side effects are going to be like this and that, but you really must take these things. So a lot of that is down to us explaining it and us going out as paramedics. We haven't prescribed it, but maybe having a chat with that patient about why they're not taking it and trying to get to the bottom of it and help them out with that and explain it a little bit better. And then the unintentional ones. So if they keep forgetting, is there something that we could put in place to try to remind them? And these things are brilliant for that. You can put up set up reminders and things like that. And drugs company too are trying to help with that. So they put little date stamps on the medicines, like the Monday, Tuesday, Wednesday, and you go around with an arrow. If my kids are on antibiotics, I always make a list and I tick it off because I can't remember if I've given it to them or not. So there's lots of different things that we can do to help with that, and that's really important for us. Just to have that conversation and open it up so that we can try to get to the bottom of that. And there's some references there. So, but bear in mind that you do play your part enormously in this. I've just read a document today, a website. It's called Making Every Something Count, Making Every Contact Count. And it's about sort of nudge psychology. So every time we go out to patients, just talking to them about what's underlying in their lives and what's going on, trying to sort of understand why they're not taking their medicines and trying to sort of nudge them to be more healthy and proactive in their health. That was quite interesting. So there's some references for you that back those up, but there are loads and loads of references around. So have a look into that. So I have told you all of that because there's a lot of patients on there on a lot of medicines. A lot of them aren't taking them, so we need to bear that in mind. So when they hand you that little prescription list, they're not on all those medicines. Some of them they're not taking, they're taking their sister's salbutamol. And there's also a lot of illegal drugs around as well, sort of herbal remedies and things like that that people take. So just be aware that it's not the sort of true picture, and we need to dig a little bit deeper to find that out. So how are you all doing? Do we want to split this if I'm going to teach the whole thing and you'll be like, oh my God, stop talking, woman? You want to keep going? So Veronica says, good. Dora says, yeah. Mark says, fine. So yeah, we'll keep going a little bit longer. Happy days. Have to keep going. All good. Okay, thumbs up. Brilliant. We keep going a little bit. So this is my favourite bit, actually, being a nerd. This is pharmacokinetics, and it's all about these really fascinating graphs, which I shall tell you about shortly. But it's about how the drugs move in the body. So it's what the body does to the drug. It's not about the effect that it has on the drug. It's not the reason that you take it, but it's about the sort of levels in the bloodstream and in the body that the drug gets to. Yes, it's Josephine. I hope you're saying that about my lovely graphs here. And we draw these lovely curves and they look like this in general. So on this x-axis here, you have the time after your dose. And you can see that hopping along in little increments. So that one is time ticking along. And then you have this plasma level up this y-axis. So what you do is you might take an oral drug and then you would take little aliquots of blood and you would test the level that it gets to in the bloodstream. And they make these sort of curves, and the sort of classic shapes of them will tell you a little bit about how that drug moves around the body. So this one is an orally administered drug, and we can see that because there's a little bit of a gap between taking it and it appearing in the bloodstream. And that is because you have to swallow the tablet, it goes down to your stomach, and then it absorbs out of the stomach and into the bloodstream. And then you can see it rising. And then it peaks up here, so that would be your peak concentration. And then it will distribute, so it might decide that it really likes fat or something like that, and it will go off and it will hug some fat, and you will see it disappear from the plasma concentration. And then it will get eliminated in some way. It will disappear out of the bloodstream. Either the kidneys or the liver will alter it or get rid of it, and you'll see it diminish, and that area, that graph will drop off there. This bit under the curve is called the area under the curve. And I thought that was really confusing at first when I started studying pharmacology. But actually all it is, it's an area that shows you how much all the cells of your body have been bathed in that chemical. So it is a really important parameter to have a look at. So if you had a drug that went up really high as a peak, and then it stayed really high for a long time, the area under the curve would be really massive, and that would really change how much all your cells got bathed in that, especially if it was quite a toxic drug. It might really make a difference to it. So that's all that is. In the olden days, they used to actually cut the graph out And they used to weigh the little squares of paper to see how much the area under the curve was, because they knew how much one square weighed. But now you can do it sort of mathematically, but that's all that means. So time ticking along on here. So that's, I take my drug right here, and then as the time goes on, it's ticking along on the x-axis, and on the y-axis, that's how high the plasma level gets, the concentration of it. So Anna says, if you were to test the patient's blood, how often would this be done depending on the drug administered? So yes, it does depend on the drug administered. So you would have, so even when they test drugs to get a license for them, you have to generate one of these curves, and you'll have done testing in animals already, so you'll know sort of how frequent you need to test them. But yes, it does depend exactly on the drug and what you expect it to do. So some of them you take very quick sort of aliquots, and what they do is they tend to put them under ice, and then they send them all up to the lab together to test them all. But yeah, sometimes you don't test very often. It's just every sort of half an hour, because you know it's a sort of very slow moving drug. And other drugs you have to test very sort of quickly. So if it's something like an inhaled drug, you might test that a bit sort of quicker, because you want to see what's going on at very small points in time. Great question, though, thank you. So yeah, so you plot your points up there, and then you join it up, and it makes this lovely curve. And from the shape of it, we can see what's going on. So pharmacokinetics, you can see the points on the curve on this one. So join them. You normally get a bit of a wiggle around the top there, but then they just smooth it off to make a nice, something that you can do maths on. It's generally accepted that they have an absorption phase. So that's that first bit there. It's absorbing out of, so the GI tract, if it's an orally administered drug. They have a distribution phase where they tend to sort of run off and hide in different places. So if it's a fat-loving drug, it will go off and find some fat, disappear. And then metabolism, where it gets changed in form, generally by the liver, and excretion, where you either wee it out or breathe it out. And elimination is a combination of those last two, that metabolism and excretion. And that will determine that last bit of the curve, sort of how steeply it goes down. No questions on that one. So that one is a classic curve. So they do calculations on these curves, and that allows us to compare one medicine with another and see what the drug concentration gets to. So very useful stuff. So key ones are Tmax. Now that is the time that it takes to get to that maximum concentration. So if we have a look, oh no, on that one. So the Tmax for this one here, so the highest point, if you measure it down, took about 4 hours there to reach peak concentration. You just mark it down, find that highest point, and you go down, and it took about 4 hours to peak. The next one is Cmax, so that is the maximum concentration that it gets to. So if we go back to our graph, that is that high point there, but it's actually the y-axis that you want to look at this time. So it's the peak concentration, and that's about 5.25 micrograms per milliliter. So that would be the concentration that it gets to. Then half-life, so this one's really important. So that is the time taken for the concentration of the drug to reduce by half. So if we have a certain amount of drug in our bloodstream, how long does it take for that to go down to a half? And it's a half-life because it's that funny shape. We can't do a full life. You can't just multiply it out by 2, because it's dependent on how much there is in there. Now, for this one, we have to go past distribution into the elimination curve. And if you look at the concentration dropping from about 4 to 2, if you drop the points down onto this y-axis, so it goes from 4 at about 6 hours to 2 at about 8 hours. And I can tell you that that's got a half-life of about 2 hours. Can you follow that? So the concentration going from 4 and halving to 2, if you find those points on the graph and you drop them down, 4 appeared at about 6 hours and 2 appeared at about 8 hours, and that's about 2 hours. So that drug's got a half-life of about 2 hours. Can you follow that one? Yep, so Veronica says also to compare drugs in terms of expected hepato or nephrotoxicity. Yep. So in answer to Veronica's question, if you altered that, so if it was a drug that was metabolized in the liver and they had liver troubles, instead of the drug disappearing very quickly like this one does, the curve would spread out, so it would go out for a long time, and that would alter the AUC. But can you follow the half-life? Is there any way to reduce the half-life of a drug? An IV drug. So if an IV drug was given, but later down the line, doctor or paramedics needed to slow the drug's effects down to allow for a different drug, is that possible? Yeah, so there are some ways to get rid of them. So if you look at stuff like I know NDMA, an illicit drug. If you want to get that one out of your bloodstream quicker, what you do is you acidify the urine, and it just changes how it's ionized. It effectively makes the kidneys work better, so that you wee it out a lot quicker. And so what we do is when people come in and they've had an overdose of that one, because it's alkaline, we give them generally citric acid and a load of fluids, and it just shoves it out of the system a lot quicker and makes that slope much more steep, and so they've got rid of it a lot quicker. So great question. Yeah, some of them you just can't change. It's just down to the rate that things like the liver works at, and you're not speeding the liver up, it just works at the same thing. Is that similar to Narcan? Can you explain that question? It's still really funny being in my house and talking to you lot. And naloxone as an antidote. Oh, that works in a different way. Thank you. So we'll talk about Narcan in a second when we talk about the pharmacodynamics. So it doesn't work on a pharmacokinetic way. It works in pharmacodynamics. So we'll cover that in a bit, but good question. Okay, so that's a little bit about pharmacokinetics. You get this sort of a certain shape of graph, and then the drug will be kicked out of the body somehow, and it makes these sort of shapes that we can interpret and do calculations on. Now, bioavailability is the fraction of the drug that actually gets to the systemic circulation. So if we're giving an IV drug like this person here, by definition, 100% of the drug reaches systemic circulation, and that is because you're putting it through membranes and straight into circulation. If we give you an oral drug, not all of it will get there, and that's for two reasons. Not all of it will get taken up into the bloodstream. Some of it gets broken up by salivary amylase, by stomach acids, and also not all of it will get out of the GI tract. Some of it just goes straight through into feces. And then the other reason is that everything that goes from the stomach goes to the hepatic system and will be taken out by via the portal vein, and it will get taken out by the liver, and that's called hepatic first pass. So stuff like GTM, you have to take that one as a spray under your tongue, and that's because the liver just loves that. It will break it down very quickly, and very little of it gets into the bloodstream. So you have to find a different way to take that one. We give a lot of our drugs by IV injection because they're emergency drugs, and we want them straight in the systemic circulation very fast at high concentrations. So a lot of the time IV is the only thing that's going to work for us in emergency medicine. But if you work in a GP centre or things like that, you can allow for this sort of alteration in bioavailability and how quickly it enters the bloodstream. So you have a little bit more to play with, and you can give things like oral medicines. So sort of our choice is dependent on kind of things like bioavailability and things like that. Sometimes you just can't give a drug. Things like morphine, if you just took bog standard morphine, put it in a syringe and put it in your mouth, it's very acid labile. So the acid in your stomach breaks it down. It just doesn't get into systemic circulation. So what we do is we make oromorph, and we've just substituted a few side chains to make it a bit more stable. and then you can take that one orally, which is a great advantage for some people. So bioavailability is the amount that reaches the systemic circulation. So if we're talking about things breaking down, we're talking about the liver. So that does a lot of our metabolism. And if we're talking about excretion, then it's the kidneys that do an awful lot of that. They wee out the drug. And some things are breathed out. So if you've ever been to somebody who's had an operation and bent over their bed to give them a kiss or something like that, when they're breathing out, they're still breathing out all the anesthetics, and they really think of it. And that is because the organ of excretion for inhaled anesthetics is the lungs, and that's how it's got rid of. So just be aware of that one. I've put this little bit up on the top right, CYPs or CP450s or CYP450s, all the same thing. These are a bunch of liver enzymes, and they'll do a lot of the metabolism in the liver. So just look out for those chaps. They're called CYPs, cytochrome P450s, CYP P450s. They're given lots of shorthand, but they're all the same thing, and people get a bit confused with those. And there's like CYP2A4. They're given really silly names, but annoying, but all the same stuff. Things to look out for, this hepatic first pass. So here we go. Drug goes, it's in the stomach, it goes through to the small intestine, and then it'll come out of into the portal vein and go straight to the liver, where the liver gets a chance to look at everything that wants to go into systemic circulation. And an awful lot of those drugs will get metabolized. You can see the CYPs here and taken out before the rest of it goes on to become bioavailable. So the liver's sort of a bit of our friend, but a bit of our foe in pharma. So we have to overcome whatever the liver's going to do to medicines and drugs. Just be aware as well that there was this thing called a compartment. So if I give you a drug and it gets into your bloodstream, it doesn't necessarily get into the compartment that we want it to be in. So if it doesn't get up to your brain and it's a neurodrug, then that's not great, is it? Even if you've got a really high systemic circulation concentration, if it's not where we want it to be, that's not good. And we need to sort of consider that things get in different places. So blood-brain barrier stops things getting up to our brains. If it gets into our brains, generally it gets into the fetus. And so that's something to consider as well. So a lot of neurodrugs are not good for the fetus if people are pregnant. And morphine, although if you give IV morphine, it's available readily in the systemic circulation, it doesn't go across the tissues and bind to its receptors for a while. So there's this delay in effect, and that's a sort of compartment syndrome, compartment sort of system where it's failing to get to its receptor straight away. So it takes a little while for it to have a peak effect, which is a bit annoying. Right, that's the last one of that slideshow. I had to split it into two because there were so many slides. How are you doing? Are you bored of me? Do you want me to log on another time, or should I keep going just for a few minutes? Personally, I'm a bit fed up of my own voice, but that's kind of normal. So Suraj, I hope I'm saying your name right. Says keep going. Only 8 minutes left. Carry on. I've actually taken the time delay, the time thing off of it. Someone showed me how to do that. So, do we have time? I've got time, but I don't want to keep you. Let's do this, says Toby. Yeah, keep going, says Georgina. Why do you lot are tolerant? Can you really keep listening? Okay. All right, so enthusiasm. Can we have a 2-minute coffee break? Sure, that's a good idea. I tell you what, I'll just keep going for a couple of minutes and then I'll give you a break, shall I? You fancy that? Okay. Oh, hang on. Is it likely that paramedics outside of hospitals will become prescribers, says Eva? Yes, definitely. At the moment, we're sort of looking at people like the advanced paramedics and the critical care, not so much the critical care paramedics, but the urgent care paramedics doing it. But we just need to figure out how we're going to look after them. So are they going to be safe? So they go out, they're writing prescriptions. Who's watching them do that? Who is distributing the medicines to the patients? So you can't really be somebody who's writing the prescription and also giving out the medicines. That makes it really tricky. because if you make a mistake, there's nobody to pick that up. So generally, the dispenser will check the prescription. So if the doctor writes a prescription, you'll go to the pharmacy, they will give you the medicine and dispense it. And there's a bit of a sort of checking process there. So we just need to be a little bit careful about how that's done. Maybe we have like an advanced paramedic writes a prescription and somebody else comes and checks it, or they check with a colleague. But yeah, definitely, I think it's going to come to people outside of hospitals. My personal view is that we don't need it outside of hospitals, because PGDs do a wonderful job of getting medicines to patients in a timely manner, and the governance around them is really good. So a PGD is a bit of legislation that gives you a medicine in your hands, and says you can give this to a patient if they have X, Y, and Z, but not X, Y, and Z. So you have to check them off and make sure that they qualify for that, and then you can physically give them the medicine. And I think that is a safer way of doing it, and we can regulate our medicines a lot better. But I think prescribing could also be useful. If you imagine people who are paramedics and do stuff like end of life care, then that would be enormously useful for them, to rather than having to go back to somebody in the sort of care home that they're under or something like that to get them to prescribe. You could write it there and then for them, but you'd have to have the speciality. So any more? I'll do a couple more slides then, and then I'll give you a break. I don't know what you're doing for the rest of the day though, so I think how I do this. Can you see? I can draw on a piece of paper and show you. So have a think for a second. I tell you what, I'll send you off with a mission and then we'll start again, shall we? So have a think about what the PK curve would look like if you gave something like paracetamol. Instead of giving it orally, you gave it IV, and what salbutamol would look like inhaled versus IV. So just have a think about how those curves might differ if you gave them in those two different ways. And then shall we reconvene after that one? So what does the PK curve look like if you give a drug IV or oral, and then inhaled or by IV? So consider those, and then we'll come back and we'll do the last bit and that when we pick up. Oh, you got Paul at 12:30. Okay. Well, let me leave you with that one. You will need a break before you talk to Paul. And then shall I sort out with Tamsin another time to talk and we do the rest of it? Because I don't want to keep you. You've got to listen to him as well. Didn't he cancel? So Tamsin. No, we didn't. Oh, yes, he did. Okay, so it does. Looks like you've got Paul at 12:30. So yeah. Oh, hang on. No fighting. Okay. I tell you what, I will stop there then. So have a think about those ones. So I want to know how the curve would differ if it was an IV versus an oral, so something like paracetamol that we can give in those two different ways, and salbutamol if you gave it in by inhalation or IV. And then I'll fix up the tabs in the time to come back and bore you some more. And we'll set it all up again as it seems to work. In the meantime, I would love any feedback from you, because I don't know how this is received. Like when you're teaching, you don't know what it's like on the receiving end of it. I can't suffer my own teaching. So please email me and let me know, good and bad. And if you really hate it, don't just say, I hated it. Say why, because that helps me. And if you really loved it, say what sort of things you liked the best. And then we'll try. Thank you, Eva. And Andrew, thanks. So send me an email and just let me know what you think of it, and then I can sort of adapt for next time. But yeah, I'll sort out the TAMS in another time. We'll go through it and maybe add the quiz on. So thank you. That's really kind of you to say that. So I will stop the recording now. I'll try to, something will break.